I'm Liz Moe, and I am the president of the Minnesota Public Health Association. I serve kind of from July to June. So I'm really pleased to be able to share some of the things that have been going on with MPHA and the things that are coming up. We always start, so the title of our session today is What Can We Learn from Each Other? And I really liked the way that in our email notification, the title of the whole series is Public Health Matters, because it does. And we're always looking for ways to underline that for people, because when public health is done well, it's invisible. And so we want to keep helping people lead healthy lives. But once in a while, we need to highlight some of the successes we've been having. Just to note, wait, go back one slide. Now I'll talk to your slide. The event is recorded. We just turned the recording on. Your cameras may be on or off at your discretion. Please keep yourself muted. Feel free to use the chat box for any questions you have, and we'll be looking at the chat and coming back to it. The moderator will be coming back to it periodically. And your moderator today is Ken Bentz. If you need help, email info@mpha.net, or there's a phone number you can text. And if you feel comfortable, rename yourself with your pronouns. My pronouns are she, her. So at every meeting, we begin with our ancestral land statement, and I will read that now. We are really proud of our statement, and it's been used in other public health organizations across the country. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a longstanding history and connection to the land since time immemorial, and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and US governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. So just to give you a quick overview of our agenda today, we'll have a few opening remarks from Ken Bentz, and then we'll hear the commentary from our panelists. We will have some Q&A, and then we'll have some breakout rooms where there'll be a chance to have conversations about the topics in smaller groups. Ken will conclude with some remarks, and I want to be sure to tell you, stay on till 9:25 so I can tell you about the good stuff happening with MPHA in the next few weeks, including our annual conference, which is coming up next week on the 12th and 13th. And I'll just say the topic for our conference is Together for Planet and Community. So with that, and we definitely want to thank our friends of the forum. Now, people who are friends of the forum have made a commitment when they signed up, have made an additional financial pledge to support the forum throughout the year. So several of these people are here today, and thank you so much for coming. And we also want to thank our sponsors, Alina and Medica. I'm going to turn it over to Ken.
Thank you very much, Liz, and good morning, everybody. It's a pleasure to see you all here this morning, and it's very nice to be introduced by my coworker, Liz. This is the last forum of the series that Liz mentioned on local and global and what we can learn from others. If you had a chance to look back at previous forums from this series, topics that have been previously covered were education, maternal and child health, and food and nutrition. There are certainly opportunities for us as Americans to learn from others in these areas. Other regions and countries do better than we do in educational outcomes. We definitely have a long way to go when it comes to maternal and child health, birth outcomes, and women's health. And we are not the best global citizen when it comes to feeding the world and preventing people from dying from hunger, even here in America. In each of these areas, we continue to produce deep inequities within our own borders. So we should be trying desperately to learn from others, as this topic suggests. In today's forum, we're going to focus on challenges in coordinated global response. Now, I'm a first responder, so respond is what I am trained to do. but my individual response is not sufficient to mitigate the situations I face. And here's a case in point from a recent incident. In fact, it just happened yesterday. You may have seen on the news yesterday or on social media that rush hour traffic yesterday morning in the West Metro was snarled due to a car fire on Highway 100 in Golden Valley at around 6:30. Well, as a member of the Golden Valley Fire Department, that happened to be in our response area. When the call came in, we were informed that the fire was the result of a police pursuit that had come out of Brooklyn Park, and that the offending vehicle was on fire and the scene was not yet secure. So we were instructed to respond to the area, but not to approach the scene. Being one of the chiefs, I responded from home in my fire department SUV, and I started in the direction of the incident. We were soon updated that the scene was secure and that we could respond right into the vehicle, which was now fully involved. We were further instructed to proceed the wrong way up the ramp from Duluth Street onto the southbound side of Highway 100, which was safe because the police had traffic fully stopped. So we did that. We put the fire out with the water and hoses from one of our engines. We cleared the scene so that the flow of traffic could be resumed. So, did you notice how many times I used the word respond in that story? As I said, respond is what we are trained to do. But without a coordinated response, the outcome could have been totally different. For example, had the police not done their part, approaching the scene could have been dangerous for us because, as it turned out, the occupant of the vehicle had a gun. And if the police had not adequately controlled the highway traffic, driving the wrong way up the exit ramp could have been very dangerous for us and for others. And if the individual firefighters on the engine had not done their jobs properly in a coordinated fashion, they may not have gotten the water through the hoses and onto the fire to put it out. So I use that example just to illustrate how important coordinated response is. And isn't the same true in public health? For public health to do what we are trained to do, that is to respond to the needs of our communities in coordination with other resources to improve the public's health and people's lives. I chuckle because, as always seems to be the case, this topic is more timely than probably the planning committee even realized when they set it up last year. It always seems to happen that way. We've seen some great examples of coordinated response, like to a global pandemic. Resources were committed to developing effective vaccines in under a year in record time. We have seen a global response to the war between Russia and Ukraine, with refugees finding their way to countries around the world. But on the other hand, we see high levels of vaccine resistance in our own country, while other parts of the world are desperate for access to these life-saving medicines. And we see countries not willing to condemn the aggression of one independent nation on another. So there's plenty that we can do better, and we're going to explore that today. If you looked over the bios that are can be seen at the link that was posted in the chat, we have a great panel this morning. People who are going to share their experiences and their perspectives on working in local and global arenas to respond to the health needs of their communities. As I said, their bios can be found on the agenda, but I'm going to introduce them briefly now in alphabetical order by last name, and then invite them to give their comments. So our first panelist is Michelle Heary. She has a wealth of experience working to affect change both locally and globally, and as the executive director of WellShare International. Dr. Murugi Mutiga has deep experience in community nutrition and leads the community engagement team at Washington County, working within both the public health and environment and community services departments. And Dr. Halkano Tura comes to us from a nutrition background also, and has led many health equity initiatives. And he is now the director of the Center for Health Equity at the Minnesota Department of Health. So we're going to have a really great session today. With that, I'm going to turn it over to Michelle and let her begin her comments. Michelle, go ahead.
Yeah, thank you, Ken. You cued my thoughts very well. So I really appreciate it. But again, isn't that how this works? There's magic in how things come together at the right time, right place, and the right people are always in the room. So thank you. And I just want to take a moment to thank MPHA for organizing this and for keeping, not just this forum, but dialogue around public health going in the state of Minnesota. And recognizing all the volunteer effort and donors that make that happen. I know that that's not easy. That's a commitment of heart and mind, so thank you. Yeah, so gosh, it was interesting to get this invitation and to reflect on almost 30 years in public health, and try to, winnow it down or select those key kernels. What's the core of what would be helpful to talk about today? And what I settled on was, again, picking up on some of the things Ken talked about. Ken identified the word that he was repeating, which was responder, right? The other word he said many, many times is we did, but we found out, and then we, and that's what really rose to the surface in my own reflection on where are we at collectively, locally, and globally in the public health sphere. And I have great hope. I think the future is bright, even though at many times the news headlines and a given moment, things might seem dark and heavy and an uphill battle. But just, again, taking that step back and looking at the macro, I have such faith in human capacity to come together and to jointly problem solve, to coordinate, to collaborate and learn. I do think that in the recent 2 years and maybe even prior that, politics definitely is in the public health sphere now. We can't avoid it, right? And it always has been to some degree, depending on the topic or the issue at hand. But it's very much in the midst of our work now. So over the last, I'll say, few years, one of the things that has really, that I've spent a lot of time thinking about and working on is inclusion of voice, and trying to navigate spaces where people are drawing hard lines in the sand of this is right, this is wrong, these voices are out, these voices are in. And I think it's one of the critical pieces of work that we have in public health in the coming years. I have full faith that we'll come back to working together with people across different divides of opinion, approach. But we're not there right now. And I do believe that we are stronger together. And when I say the we, so we, let's define we, right? I do think it is this global local. I think in the micro, at the household level, when we're talking about health practices, health decisions at our community level, in our state, in our nation, and then globally, that's where we have the opportunity to show up in a way in dialogue and conversation and action that is a bridge builder and brings people together. Because I think these big sticky problems that seem to get more and more complex and come at us faster and faster, it is going to require all of us working together. So that, to me, that's the biggest sort of surprise at this point in my career, to see where the public health sphere has come in terms of some real strong polarization in certain areas, and exclusion and marginalization of voices. And I really just call us all to engaging with others, again, local meaning in our households, our community, our state, and then internationally, to really be open, to listen, to share our ideas, have the strong debates when they're there, but also really be good listeners. I think there are probably so many lessons learned globally right now around the pandemic, and how different nations, different local communities responded, given their set of resources and needs and opportunities. And I hope that we give more space to hear from those folks. In the work I've done, I've worked in grassroots level overseas, domestically. I was raised in a house where science was a religion. Anything that wasn't scientifically proven was, kind of poo-pooed and thrown out the window. And I tell you, my greatest learnings in my career have been in small local communities, little working groups of people from all different walks of life. And with being at a table, open heart, open mind, and not coming and saying, this is what the answer is, and trying to push an agenda. That's where I've done the most learning in my life. And my personal life and professional life are sort of, mixed, right? So those are my opening thoughts. I think it's a time of hope, but I am calling my own staff overseas, here locally, and my broader global professional health network in quiet ways and in louder ways. I'm calling everybody to be good listeners, to show up at the table, see the humanity in the other person you're talking with or the other people, open-hearted, and listen. There is a grain of something you can learn and something you can take, and then collectively we come back together and we can make a difference. So those are my thoughts.
Very good. Thank you, Michelle. Let's move then on to Dr. Mutiga.
Okay, thank you so much. Thank you for having me here. I'm very grateful to be here, and grateful to those who've come before me and paved the way for me to be here. I know that I do stand on the shoulders of my ancestors, and I move guided by their wisdom and strength. And so, so this topic is obviously very interesting to me with my background in public health, nutrition, even education. And what in the last 2 years have done is exposed the disparities that we knew already existed. And here in Minnesota, even from the report by the Minnesota Department of Health, Advancing Health Equity back in 2014, gave us a good overview of these health disparities. So what the pandemic has done is now increased the urgency of addressing these disparities, and of course, in a more coordinated way that is inclusive. And when we look at some of these disparities, we'll see that, there are certain communities that, yes, are not enjoying, good health and access to resources here, but also abroad. When you start looking at even the way the vaccinations are going, some countries, low-income countries, could be even as low as 3%. Some, like for example, like maybe the Democratic Republic of Congo, like 0.9% are the ones who are vaccinated with 1 dose. 2 doses, 0.6%. That's very low compared to where the higher income countries are. And there are reasons for these disparities in terms of how the cost that was very difficult for some of the low income and middle income countries to access, but also delays, even those who ordered, the delays, were again also, there were disparities with that, and were kept waiting. And some even ended up paying more than the high income countries. So these disparities, again, are things that have to be addressed. But they also do have their backgrounds in, whether you look at it locally and internationally, there's structural racism, as named even in that MDH report. and also colonialism, those long years of colonialism that left a lot of countries vulnerable and communities vulnerable, and loaned these monies that had so many conditions and are left now with debts. They're using, some of their incomes now to service debts. And others, colonial powers still have a lot of hold on them. You hear of from Francophone countries that still require, the France still requires, that those Francophone countries store some of their currency reserves in France, because without them, then maybe France will not survive too. And this continue. So this all end up, these colonial governments and these patronizing policies really take away from the investments in building infrastructure that would help countries be able to. And some of these countries are very rich countries in terms of the resources they have, the low-income countries, but that is siphoned out in other ways. And then also thinking about research is also another area that is of interest to me. So how we carry out research. So when we're working with communities that are affected, that are living in this, with these inequities, that are marginalized, how do we do our research? Are their voices included? Are they leading the work? Because they are the ones who know where it hurts more. Even in the countries that are also going through this globally, how much of their research is valued and included. So we have to use more action-oriented and participatory approaches that engage communities. I mean, there's been research has been for a long time centered around, very academic centered and driven. And a lot of times it does, show what's going on in the communities, but people will usually go and publish big papers, but really leave the community as is. And the communities have said, no, we now wouldn't even, we don't really want people, because we keep talking about this and nothing changes. But then when community leads the research, we see changes happen because it's more action oriented. And this was part of my research for my PhD project. I used more of that action, community-led, working with community-based organizations that are in these marginalized communities here in Minnesota, mainly the African immigrant community. And we were able to address some of these nutrition inequities in the school districts and pass policies that were more culturally responsive. And that was led by the community, and significant steps taken that were beneficial. And so we have to do more of that kind of research. And even across the borders when we think of the low-income countries and communities, the same thing, because I think sometimes researchers do come to these countries and take a lot of information, but don't engage or see those local communities as experts in their field. So there has to be a more coordinated way of getting this research so that it matters abroad, but it also matters, locally and also abroad in a way that will bring about change. I have seen some research done here that is community owned and managed, where the community is the principal investigator and project manager of this research, which is a shift, because usually it's the academic institutions and that's who the big funders go to. But what if we change that and give that to the community? And then the academic researchers are really just engaged as consultants. I'm thinking of a group known as an organization known as the West End Revitalization Association in maybe in North Carolina, that had this kind of approach, and in terms of, and they use that to assess safety and adequacy of water and sewer services in 3 low-income African American communities in North Carolina, and it works. This is and so it shows a model of what difference it makes in addressing the issues people are facing every day. So we have to think of decolonizing ways of addressing this and investing more in communities and building capacity so that they're not waiting, but people are able to develop the vaccines. They're able to have enough capacity to, take on, the next pandemic that comes. So even and looking for ways, and it's an encouraging thing in some ways. What we saw with the pandemic, where people came together in a very coordinated way, and even the way travel went, the isolation, the development of vaccines, and the sharing of information, there was some coordination there that happened between different countries. And so we can leverage that. We can take some of that and use in future to coordinate how we respond, because now we are so connected globally that what's happening here, other people are listening. I remember even just the daily briefings from the governor in New York would be heard around the world and really educated a lot of people. So those are things, and that was free. And so we eliminate even the need for having people paying these high amounts to travel from other countries, even some of these low-income countries, to attend conferences. Now we can coordinate with different countries and just have these conferences where we share really good information, because we saw we can do that. I want to give an example in Kenya, where I am from. What they did is, one of the examples they did is that the public hospitals across the country came together and had a group that used to meet weekly during the pandemic when it started. They had over 900 registrants. I mean, they would meet in groups and just have and do a Zoom conference. With China, when it started in China, they had doctors talk to them. What is happening there? How are things going? What should we be prepared for? And then they also met again, and this one I was there listening with doctors here in the US who are dealing with pediatric care, nursing care, emergency room care, and also included, which was important, a disaster management professional. And so all those listening to what's going on there as they prepared, because they knew they did not have the capacity to take on, but they had to mitigate it early. And that was a very great coordinated way of learning from all the different places, because and anticipating it is going to travel to you. So we can use these channels of communication in a very coordinated way that can make a big difference. And even just what we are doing, even with telehealth, we've really been able to get to people. I know it also introduces other inequities, but I think there is a way we can come together as and bring public health, politicians, medical field, disaster management, researchers, and coordinate better care. And address these long-standing systems and practices and policies, and and do that, and hopefully that will move us forward. It's challenging, but it's doable. And I will end there for now.
Thank you so much. And we'll move on to Dr. Halkanotura.
Thank you so much. Can you hear me, Ken? Great. Yeah, thank you so much. I too thought about this session a little bit, and then I thought what should be helpful, what can be helpful in this session to talk about. So my opening commentary is going to really kind of laser focus and shed a light on the things that both Michelle and then Dr. Mutinga try to address in this. So for me, when I look at specific to this pandemic, both local and global, what the pandemic did was it made structural and systemic inequities painfully clear in all regions of the world, both in the global south and the global north. And it compounded these long-standing and often overlooked, comfortably ignored inequities. So when I look at that, I think I thought it is really good for us to pinpoint this and shed more light on the structural and a systemic issue that is perpetuating, continue to perpetuate inequity and increase the vulnerability for some of our communities. I think it is important to look into that because both the impact of the pandemic and our response to the pandemic did not affect our communities in equal way or equitable way. So that brings up some of the structural and systemic inequities that existed for a long time. So when I see and I look at these inequities, these structural and systemic inequities, I see it at three different levels. One is with the citizens of the global north, sharp rise in mortality and morbidity among minorities in the global north, with our Black, Hispanic and American Indian community absorbing a large share or a disproportionate share of the impact of the pandemic. As you probably see in this, the most recent study suggests a life expectancy drop that eliminated much of the progress made in narrowing Black and white life expectancies and nearly eradicated the advantage of the Hispanic life expectancy. So you can see that it is really, by now, it is scientific fact that racism is a fundamental cause of health inequity. The structural and systemic racism constrains access to health promoting resources and opportunities, and equal distribution of health-related risk and exposure. And it also drives this generational trauma that imposes a more significant health burden among the marginalized communities. So these effects reveal the underlying system of structural racism in the global north that have historically resulted in inequitable treatment, access to health, access to opportunities and the resources, and then in addition to that, the public health response to the pandemic did not help either. So as we all know, early many the pandemic did not really fit into the situation of the most marginalized community. Many marginalized and minoritized group, for them isolating or staying home was not a safeguard they could afford. So you can see that how the systemic and structural inequities in the global north significantly impacted and put those community, the minority community, at a greater risk when it comes to the response to the pandemic, and also the impact of the pandemic. The second group that I really see through this lens is the citizens of the global south, right? That Dr. Mutinga and then also Michelle alluded to, based on our own experience in the global south for many years. So despite being slightly different, Dr. Mutinga actually alluded into this. In the global south too, there is injustice from the leftover colonial ideologies that have help preserve the current structural inequities developed from these injustice, structural inequities, and unfair policies reinforce the socio-economic imbalance and effectively determining the living condition of population and creating health inequity in the global south. So the COVID-19 pandemic response in the global south, as you know, as prior speakers alluded to, is under-resourced. Citizens and the leaders of the global south are overextended, further due to their deep-rooted scarce resource settings. And then what is happening in the global north, especially the vaccine nationalism in the global north, has not helped response in the global south. Democracies keep vaccine for themselves. As you all know, early on, the largest vaccine donation that given to the global south was from the autocracies, right? And national leaders and prioritizing vaccinating their own citizen is understandable, but the extreme inequity in vaccine access is hindering the global effort to combat the pandemic. So it is also, to be honest, it is short-sighted as a diplomatic matter. So for me, the other greater concern, as a person that spent most of my time in the global south doing public health, what is most concerning for me is the vaccine diplomacy efforts that suggest donations are a means of cementing a sphere of influence rather than advancing vaccine equity and ending the pandemic. So you see that structural inequity playing out in the global south too. And then really the third group of community where we see both our response and then the impact of the pandemic play out is with the refugees and the displaced and the migrant community. As you all know today, over 90 million people across the world or worldwide have been forcibly displaced. So these individuals are usually neglected by countries' preparedness plan. They are lost at the sea and lost to the institutional system trying to address the health issues in those countries, wherever they are. Those forced from their home for safety then became much more vulnerable to COVID-19. So with the spread of misinformation and refugees and displaced migrants experience increasing stigmatization. So today with this opening remark, I thought it was disservice if I don't at least mention this group that is also absorbing a disproportionate burden of COVID-19 because they too need to be part of the overall effort to curb the pandemic. So as kind of final point, the effect of the pandemic is going to stay with these three group of communities for many years to come. From the equity point of view, at least where I stand, endemicity is meaningless. When we say COVID is over, we generally dismiss the experience of those groups of communities. For them, COVID is far from over. So I think it is important when we say, oh, COVID is going away, we are really dismissing those group of communities that we need to be extremely mindful. For those of us who are privileged by income, where we live, or the color of our skin should not be the determining group when concluding that the pandemic is over. For the public health, especially for us as the public health professionals, the way out of the pandemic should be the same as our goal in every other public health initiatives, making sure that we get everyone to the finish line, not just a select few. We public health professionals, we did this many, many times in many other global pandemics, where we work together, we brought all to the finish line, every group of people, regardless of who they are, where they are from, their skin color, or how they look like. So there are challenges and hurdles yet ahead of us, but we must continue to put our strengths, talents, and toward ending COVID for all people, all group of people. So With that, I should stop here, but really what I was trying to point to is both in the global south and the global north, there is this structural inequity, systemic inequity, historically perpetuating vulnerability to group of community. As a public, as really we need to be mindful of those group of people.
Thank you very much. So really great perspectives from our panelists. And Michelle, I'm actually going to direct my first question to you. Since both Murugi and Halkano have talked about pandemic response, which is no surprise given where we are with everything right now, that's dominating so much of what we think about. But Michelle, your organization has staff located around the world, both in the global north, the global south, as Halkano mentioned. And how has the pandemic and the response impacted the work that your organization does? And what do you see as some bright spots, maybe looking to the future?
Yeah. No, we've been partners with MDH in the local COVID response work before there were any grants out. I saw it was because my network is global. I saw what was happening in China. I saw, the news elsewhere before it hit here. I literally picked up the phone, I think late February, first part of March, and talked to our partners at the Center for Equity actually, and said, this is not small. It's coming here and it's not going to go away quick. We are here, we're ready, this is what we can do. And so we actually started the health education material production. We were doing research before CDC and the state had it out. So we have been in Minnesota, we've been frontline responders since first part of March 2020. So I'm going to talk about Minnesota first. And so this means, and about 85% of our staff are themselves first generation immigrants. So again, I can't really separate completely professional from personal. We had to not only do the public health work, boots on the grounds, education, helping mobilize people, getting them to vaccine testing clinic sites, but internally, the way we ran the organization had to change significantly because, as has been pointed out, our people on our team were significantly, impacted in their homes, and many of them lived in multi-generational homes. There was care for elders who got sick, care for young kids who were home. So overall, like, our lives have really changed completely. We're working weekends, evenings. It's slowed down because funding is slowed down now. But we are already preparing, and we've got strategies to address some of the issues that have been talked about. COVID is not over. And so we're continuing, we will continue to promote vaccination, testing, do the education piece, but last year, we also started integrating into our COVID work, mental health support, services, education, referrals, that kind of thing. All of our staff have been trained for their own self-care and to help communities manage anxiety, stress. They've all been trained in mind-body medicine, stress management, that kind of thing. So, and I didn't imagine that's something we would be using in the workplace and bringing out to the community, but COVID brought that. And I think it's a good thing. That is one of the positive outcomes, is I think we're really now, the world has woken up and we're addressing mental health challenges, opportunities as well. So that's changed. Yeah. And then the other piece that we are really talking a lot more about is general health status, nutrition, eating, getting outside, all these things that make people more or less vulnerable, whether it's COVID or the next thing that comes. So we're looking at health more generally. COVID has caused us to look at what we do in terms of health promotion, health education more generally. All of what I just said applies also to our East African teams. It's been interesting. We were really afraid that our East African teams would be impacted more even than we were here. They weren't. infection rates in the communities that we partner with there were lower. And or there was less testing or less morbidity. So it's been really interesting. The biggest challenge we've got there now is crops failed. So it was a very bad year in terms of agricultural production. And so a lot of our own staff, actually, I think we've got 35, 37 CHW community health workers working in the field every day there. A lot of them have had to leave health work and go work in mines now because their livelihoods from agriculture have been upturned. So that's almost the bigger crisis in our particular partner communities in Tanzania right now. So in summary, kind of just agility, be alert, be aware, respond quickly, do what you can, but look ahead. What's the next thing? And, mental health, that was in 2020, we saw that because our staff themselves were bringing that to the table and talking about it. And so I'll stop there.
All right. So I'm being mindful of the time.
Yeah.
We want to keep things moving. And I want to ask one more question before we go into the breakout groups. And this is for Halkno. I was really took notice of what Marugi was saying in terms of research considerations that have impacted her work and who's represented, who's doing the research, are communities engaged. I'm curious from the Center of Health for Health Equity, how are those considerations informing the work that you're doing going forward? And let's try 2 minutes or less because we have to go into breakout groups too. You're still muted. There you go.
2 minutes. Thank you. Just like I said in my opening remarks, trying to focus on the underlying structural issue. At the same time, one of the things that we really learned, for me, I was in an international setting for over 11 years in 7 different countries. One of the greater learning that I see applied here in Minnesota is engaging the community in the process. So where data is coming from, what is the representation of the data, how we are applying research in there, how are we challenging the structural issue even in the data process, data life cycle, data collection, data analysis, data interpretation and sharing information. So that is basically some of the experience from the global South that we are infusing more and more into the response here in Minnesota, which we've seen a great success in terms of engaging community. I think one of the key things in this is what kind of community engagement we're talking about. Are we engaging community in an authentic way? Are we addressing this pandemic in a culturally sensitive way? What kind of research and data we have around that? So we've been doing several data collection, data analysis, and then also talking to the community, really spending time with them, engaging the community, being present, working with our local public health partners and being present in the community, listening to the community, different religious group, different and ethnicity, and really culturally appropriate to address this pandemic. I think that is the best approach, where communities are not just included, but they also feel they belong in the process of responding. That creating that sense of belonging to the process. I think that is one of the things public health can benefit from. I've seen when I was working with the USAID grants in international settings to curb malnutrition, and we were able to reduce malnutrition by 45%. Child mortality by 45% among children in a global setting. That then through engaging community. We know as a public health, we have that public health background and we don't really dictate, but we listen to the community. So that was extremely helpful. I think in terms of research, that is what is going to be helpful here in Minnesota too.
Okay, great. Before I turn it over to Lindsay for instructions on the small groups, I really hope people will stay, go into your small groups, have your discussion, and then come back, because it really is interesting when we tie this all together. So Lindsay, go ahead and we'll go into the small groups.
Great. Thank you so much, Ken. What a wonderful first half of the forum. Okay, now my colleague Emily will, in a second here, invite you to a breakout room. So please accept that invitation in a second. I hope you met some new people and created some wonderful questions. My name is Lindsay Fabian. If you would please have one person or a couple people from your group send me your questions you came up with, or questions you have as an individual person or something you came up in your breakout room. Please chat those to me right now and I will direct them to Ken. And so feel free to send me your questions. And Ken, I'm going to turn it back over to you to start the Q&A part. Thanks,
All right.
Ken.
Sounds good. I hope you all had good discussions in your small groups. I've always found those to be really interesting and getting different people's perspectives on what they heard during the first half, and then having discussion. And it's always been hard sometimes to narrow down, okay, so what's the question we want to ask? So hopefully we got some of that, and I'll be watching for those to come in from Lindsay. One of the things that I heard in the first half was actually a comment made by Marugi about technology, and how, from a research perspective, just like we are today, having the ability to communicate via Zoom or other technology, we have people here who could, people could be on this meeting from anywhere in the world if they have access to the technology. And so that's always an issue. We know even in our own state, not everybody has access to reliable Wi-Fi or to the technology to conduct meetings like this. And so, and as somebody pointed out in an earlier discussion, sometimes access to the technology is limited by the government or by some other forces. And so these are all choices that are made by people that impact what people's experiences are and what they have access to. So I'm going to ask each of the panelists to think about and respond briefly to, how have you seen technology either being helping people have access or being restricted and not allowing access, and how have you seen that through your work? So since you brought up the issue, Marugi, I'm going to start with you.
Yeah, so there are, ways that technology has really been able to reach many people. Even part of the work I do is teaching, and so we've been able to reach students far and wide. So in that way, it does. But it also does point out to the inequities that exist between, those who cannot afford. And so what the schools had to do, or college had to do, is to invest more in getting these resources available to all students for free, so that they can easily access computers, but also access the internet. And so that way it helped. So, but in terms of now internationally, obviously certain communities will not get, but then there are also local ways of passing information. So taking advantage of those. So now we are getting information very quickly, but then how does that translate locally? So using local ways of transmitting information, there, just like, not every place would get a newspaper, but there's that one person who then translates for everybody else what's going on. So having those grassroots way of passing information to different people. But yes, it can be controlled, but at the same time, there are so many channels now, and people have figured ways that information is still able to go, but it has to be, again, in a more intentional way of getting it out. Yumi, I can't hear you. Mm-hmm.
Thank you. How have you seen the technology question impact the work that you do?
Thank you so much. As in many ways, one is just as you said, Ken, earlier, technology has been kind of just like a two-edged sword, right? So in one way, it is really very, very important for the work that we do to easily get information to people. That is the first thing. At the same time, technology also increased that misinformation to get to people and disinformation very easily. So that is other side of it. I think if properly used, technology can still continue helping response to the pandemic, and anything that we do for that research. During the last 2 years, I've been doing a research sitting here in an international setting because of technology. Just Dr. Mutinga in Western Kenya, in Kakamega County, I was doing a research sitting here because of technology. It was possible now to do research from far places if you really have a people on the ground, and then there is a technology access on the ground. So it helped us to get to the information, get information from the community very quickly, and learn what is going on in the community very quickly. So that is the good side of having that technology. But this technology, again, is not equitably distributed. As you know, in a rural area, for example, there is a broadband issue, right? So there is what people call it a digital redlining, the grandchildren of redlining, which is digital redlining, where you see a neighborhood don't have access to broadband internet. The same thing that you see here that I have earlier when I was talking, but some issue with internet light is basically because of the neighborhood where I'm living in, honestly, because 5 miles from me there is a very fast internet access. Actually, they call it the third in the global world. In terms of speed, internet speed. So there are hindering the response.
And then back to you, Michelle, same question.
Yeah, I feel like our internationally, mobile phones made such a difference a long time ago. Back when we all had flip phones, we were using SMS messages to educate people through that. So we've continued to do that. That is not new necessarily. We did bring that and apply that same approach here in Minnesota in our programs. And it was more or less successful. What we found actually helped more was WhatsApp groups. So I don't even know if you call them social media or just like group communication technology groups. So, yeah, but it's interesting. It's a little bit of like, I don't want to say guerrilla warfare, but that's what's coming to my mind. It's a little bit more chaotic and less organized. You know, it's organic. It's driven, like in our case, our staff are of the community that we work with and serve, and so they are parts of these groups already, and their own networks are being leveraged through their existing WhatsApp groups, that kind of thing. In some of our rural East Africa programs, so we do SMS, health ed through cell phone. A lot of people have cell phones, but beyond that, we just did the old-fashioned, get the van and the truck out with the megaphone on top and call together and drive from village to village and call together group meetings in person, practicing social distancing and outside. And so we did the old-fashioned thing there. I'd say back to Minnesota side, we really leveraged Facebook, YouTube. We put a ton of material out on social media. And so that's what we did. I don't know that technology made a huge difference for us in this because we were already using it to the best of our ability and the capacity of our communities before COVID hit.
Well, I love that image of the technology of putting a loudspeaker on top of a van and driving around with messaging. And hey, there are times when that works, right? And so that's making use of the resources that are available and the techniques and technologies that you can. That's good. Well, a lot of things that have been mentioned, a lot of topics that have been mentioned today around research and technology and access to health resources and treatment options. And, those are all related to public health. Those are all things that need to be interconnected to allow people to have the greatest opportunity to have good health. What are some things, what do you think is the highest priority for things that we should be collectively investing in to get the greatest impact in improving people's health? So Michelle, you can be number one this time.
Well, I do think it's nutrition. I do. I think so much, you know, we're talking COVID now. There's going to be another thing. COVID's not going to go away completely. And I do think nutrition in terms of health areas is really, really important. It's our bodies, it's the bedrock of health, is the condition of our bodies and, you know, day to day. So I think that's really important. And that, of course, is connected with all kinds of social issues. So I guess I'll add to that is whatever the issue of the day is, or whatever the issue of the decade or the century is, take a systems approach, look at it holistically. It's not just like one technology and getting it out there is going to solve it. We have to look at the whole systems. We have to, I'm going to say this. I feel like our COVID response was a little bit too much. We've got the technology. We just need to get it out there, and not enough of what are the systems that everybody's living in? What are their, you know, beliefs, and working with people and organizations in a more holistic way. I look back at, like, I started off in family planning, reproductive health, that work. We made so much progress in that field. And we looked at it so holistically. There was clinic, quality of service, there was educating individuals, educating couples, educating families, looking at access issues. It was so multidimensional, and there's been major progress made in people. And the other thing too, this is really important, is balance in individual human rights, health rights, and collective. That's a space where we had to navigate that all the time. Population planning, goals, targets, and individuals' rights. And that is a huge thing that we need to do a better job at in other areas of health as well. I'll stop there.
Thank you. Marugi, same question. In your opinion, what's our highest priority for investment today?
I think we have to invest in communities and build their capacity to handle some of the problems that they face. So looking at, the different social determinants of health and making sure that those are invested heavily in those communities that lack. So recognizing that communities are facing all these different issues, and there are historical reasons for them. So acknowledging that, but also now putting money where our mouth is, that we really do care and do what we are, what's required in investing there and building their capacity. So I think that's important. And also institutions or the powers that be, recognizing that they cannot hold on to power for too long, that it's time to start, relinquishing that, and recognizing that the power lies within the people and not these institutions. And so even as we work in these different institutions, a lot of self-reflection and recognizing what are these areas we need to work on, so that as we build capacity in the communities, but we are also building our capacity in terms of working with different people. So yes, I would say really investing in the infrastructure and all these different determinants of health that come in the way for community.
Thank you. And Halkano, same question. Investment, highest priority.
Thank you. I think I would just echo what Michelle and Murungi was saying in terms of what the priority for us is. The priority is, one is just upstream transformative approach. Don't forget system. We've been tweaking policies and different things for many years without really touching the system. And it gets us where we are right now. I think regardless of where you are, global north or global south, really focus on the system, the social ecological model approach to what we do. Look at the system. And then the other area, it means and what it takes to authentically engage a community in a very true, meaningful way than just like sharing information. Some people call it community engagement. So I think the two are a key priority: truly engaging community and focus on a transformative approach, which is the upstream approach to addressing any public health issues.
Thanks. I really appreciate all the great questions that have come in. I know we're not going to get to all of them, but that demonstrates that you all had really good conversations in your small groups. So a little bit related to what we were just talking about. So engaging the community, getting community voices to be heard and to be incorporated into research also requires that they be integrated and coordinated with good, hard quantitative data. We want to have data-driven solutions. So how do you see that happening today? How are we integrating the good data and integrating community voices? And so how can I'll start with you this time?
Thank you. I think that is really great question. One of the things is data is critical, right? For us as a public health, data is very, very important. We need to be basing everything decision we make on data. But I think before we get to the data itself, I think we need to question the assumptions behind the current algorithm related to data. Those algorithms that are used today, the assumption behind any kind of data analysis is really the assumption based on a certain group of scholars assumption. It doesn't include the whole voice of the community. So I think that any data analysis, any data collection and process that involved, so that we really incorporate the voices of the community, the assumption, their own way of learning or epistemology into the process of data. The whole data life cycle. I think that is an important point. And then really interpret data. One of the challenges, especially Ken, you mentioned about quantitative data. The major challenge with the quantitative data is it lacks a lot of, it has a lot of challenge. We don't get into that, but we need to be careful about telling in the single story of the community. So data in most cases doesn't tell the whole story of the community. It tells you the negative, it doesn't tell you the resilience. So it is important to use data, look at the whole story of the community. Single story of a given community create a stereotype. And it really leads us to continue perpetuating inequities. So I think it is important to look into that, and it's an important point.
Murugi, your turn.
Yeah, I think I echo the same thoughts as Dr. Tura. We have to qualitative data and capturing people's stories and their ways of doing research is really important, and it has to be included from the beginning. So even in determining what the issue is and what the issue is of priority, that's where you know, the community is engaged from. So, and whatever, because data, okay, data is there, quantitative data is there, but it doesn't tell the full story. And also the other part that's missing is even the spirit of it is never captured quite by these numbers. And the spirit in which a lot of these communities are doing this work gets lost. And so I'm a big proponent more of, yes, the quantitative data is important, but really the qualitative is more, and capturing those stories in the way that they are told by the communities, using the language that they can understand, so that as they go through the whole process of research, that even in the end, when whatever report is done is something that they can understand, that they can relate with, that is we can take action steps on that makes sense, because that's what's more important, that it's bringing about a change rather than, you know, having this sometimes big numbers that may not be as meaningful to the community. So what is of priority to the community that makes a change is what we go by. And if quantitative data means a lot to them, and that's something that they want, then we do that. But they are the ones leading with their voice in terms of what will make a difference for them, because this is their lived experience every day, what they're living with. So that's what I would say, that it's important that we capture also that spirit of the community that gets lost in, when I read some of these very heavy data research, journals, I'm always wondering, what did the community say? How did they feel? And that sometimes gets lost.
Great, thank you. And Michelle.
Yeah, there's data at different levels, right? People like us, we can look and absorb and use data in one way, and then there's the general population. So I think I would respond differently depending on who the audience is. I agree with everything that's been said. One of the things that I wish we could do a better job at is framing data to the general population in a way that is not fear-inducing, it's informing. I feel like a lot of what we've done is just increasing fear, anxiety, division. And so how do we bring data to the general population in a way that allows for informed decision and choice and is not an additional stressor? That's one thing. The other thing that kind of circles back to earlier comments, I was listening to a lecture recently by an amazing Indian woman who focuses on the agricultural sector and health and nutrition related to producing food. And she just gave a really good reminder. She said, it starts with what you measure. She said, historically in food production, everything is about volume. It's a quantity. You're measuring how much production of this, how much of that. And she said, when you go and talk to the Indian villagers about what they want, the farmers, to what they want to measure. They want to measure what's the nutritional value, the quality of the food I'm producing. What's the state of the soil that I'm leaving behind, depending on what I put into it and what I take out. And what is my long-term, economic sustainability and security. So again, that was a powerful example to me of how the whole research question is very complex, but even just taking that first step, what are you going to measure, is really important. And it depends on the audience and who's driving it. Is it a volume question? Is it a quality question? Is it a social, benefit question, etc.? So those are my comments on that.
Okay, now here we are with a speed round. So in 1 minute or less, as a public health community, what are some concrete actions you think we can take to help break down some of these structural issues that impact our communities? Muruga, you're up first this time.
Some of the steps, for example, in the work that I'm doing, the community engagement person for the county. So investing in getting out to the community and listening to the community so that we can begin to hear. So, and at the same time, looking within ourselves, our institutions, on ways that we can begin to reflect on how we do things, and moving away now from this community is the problem, or community deficit or person deficit, to more, let's look at our systems, let's look at our policies, our practices, that we start to change so that we are ready to have now these mutual relationships, trusting relationships with our community. So yes, so investing more in really hearing from the community, but also within, working within to change ourselves so that we are ready to work with people who don't always think like us or work like us.
All right, well done. Halkano.
We heard this several times, but for them without them, with community full engagement, and that is one. The other thing is collaborate. Collaborate, and collaborate. Our community is one of the puzzle in the whole system. If we want to transform the system, collaborate.
All right, and Michelle, you get the last word on this one.
Sure. Put people of the community, you have representative staff and leadership. At WellShare, we are the community. So, our staff are the drivers of it. They are the community. And it's not easy but we don't have to go through all these extra steps to like reach the community. Our staff are the community. So that's one thing. I think also funding. I mean, the way funding works, federal government, state government, et cetera, those community-based grassroots organizations that are in the community, that are made up of the community, they are not funded. They're not funded adequately. There's a lot of inequity in the way funding is applied. So that's one systemic thing that I think would make a big difference. So staff, you know, have leaders that are of the community. Don't have 3 degrees of separation, so you have to figure out how to get to community. Make yourself the community, you know. And then staff and pay them equitably. Don't make community-based organizations struggle to get by. It's not fair. You'll lose the best people, you know. So.
Well, I want to give huge thanks to our panelists this morning. As always, we've scratched the surface of a really broad and important topic. So you've had great perspectives, and so I thank you for that. We heard some really great messages today, some great ideas and some great suggestions. So there's a lot to think about, and so I'm grateful that we can record these so that we can go back and review it again and think about it some more. So with that, thank you all. Thanks for staying and being here. And back to MPHA. Is that you, Lindsay?
It's Liz.
Hi, Liz.
But I just wanted to say I put everything in the chat. So please become a member of MPHA. Please come to our conference next week. It's going to be great. It's really going to be great. We've got a fantastic panel. I sent you the link to the website. And thank you. I repeat your thanks to our panel, to our planning committee, and to our sponsors. So that's it. And what a great conversation. Ready for the week, ready for Friday. Thank you everybody for being here.
Thanks, Liz, and thank you all